Hey, Ray.
Good morning, Jay. Good morning, Mimi. Good morning, Bethany. Please forgive me for being late.
Good morning.
As you know, Jay, the conference, the CHWCRS conference is also going on. And it was one of my things. It was reentry and recovery.
Great.
Okay, Alexis, is that everybody that we have for this subgroup today?
Let me see. We have Mr. Ray Lay, Missy Gardner, Barbara. Is Sharon Bowman?
She's not here yet.
Okay. I believe Brooke Lawson was the only one who ahead of time said that she wouldn't be able to attend. So we could give a little bit longer to see, but
You can give her a couple minutes.
Yeah.
Hey, Barb.
Good morning. Sorry, it took me a while to get to the mute button.
Should we go and get started?
I'd say yeah, and we can let our last member. I'll admit them once they get here.
Okay. Well, it's a small but mighty group today. So. Okay. Well, I'm going to go ahead and share. Let me know when you're ready, Bethany. So welcome, commission members and anybody watching to the inaugural subgroup meeting of the Behavioral Health Commission. This particular subgroup is kind of focused on overall mental health and well-being, and what we can do and what the government and state government, local governments, and other stakeholders can do to advance the kind of overall mental health and well-being of Hoosiers. This is our very first subgroup meeting, and so it's going to be kind of a learning process. Bethany, it's not letting me share.
Okay, so it looks like maybe Ted would need to make you a co-host, which I didn't.
You just want to go ahead and share?
I can, sure. Just the PowerPoint slides.
Yep.
Okay, give me 1 minute to get that pulled up. Sorry about that.
Thank you. So every single.
I just gave you access.
Okay. So while I get that pulled up, I will share with you all something that's very relevant about my current mental health and well-being. And I think it makes this a very timely subgroup meeting to have. So I'm currently at home recuperating from a pretty badly broken ankle I suffered on vacation. And so I've been through a bit of a roller coaster over the last week and a half or so. And so, as I've been reflecting on that, I opened up our peer recovery coach conference this morning, talking about, how, while this does stink, how grateful I am and how blessed I am to have this, big broad support network and a good job and health insurance and, you know, a comfortable home and you know, all the things that kind of go into making recovery from this, you know, recovery from this acute physical injury, but I think that applies to recovery across the board. You know, all these things that I have that make it so much easier. And I think, you know, in that same vein and same token, I think in this particular subgroup, I think we have the opportunity to think bigger, think broader, about kind of overall mental health and well-being, and you know, with the understanding that you know, making life easier for people, you know, is very likely going to have the impact of making their overall mental health and well-being easier. So, you know, this is a very unusual group. I mean, in the sense that, you know, and what we're tasked with, every single group is kind of different, and you know, some of the other groups I think will be a lot more focused on drilling down on like specific policy recommendations and specific recommendations for legislation and whatnot. We, I think, in this group, have a bit of a different challenge. You know, obviously we're very much open to talking about the specific policies, but I think that to a certain extent, just like you can't legislate morality or legislate, you know, things of that nature. You know, it's probably difficult to do too much legislation or government intervention to impact overall mental health and well-being. So we're gonna have to think about who our audience is for our recommendations. But ultimately, you know, we do want to think through the lens of recommendations, because that's really the output of this group is you know, reports and recommendations to the legislature, to the executive branch, and to whoever else will listen to us. And so, you know, I would encourage us to think in that way. Before we kind of dive in and get started, I think, you know, we have the luxury of a bit of time because we have a small group here today. So yeah, I'd like to just go around and, you know, ask Mimi, Barb, and Ray in particular, you know, kind of what your hopes are for this group, you know, who you are, what your title is, what your hopes are for this group, and just kind of overall reflect on the charge of this group and how you see it playing out. So we'll go ahead and start with Mimi.
Anybody?
Well, we'll go and start with Mimi. So.
Oh, okay. I didn't hear my name. Okay. I'm Mimi Gardner, and I'm from HealthLink. I'm the Chief Behavioral Health and Addiction Officer. And first of all, when we were signing up, what I liked about this group is it looks at, I see the whole person. And I'm about integrated care. So we're looking at the primary care needs as well as behavioral health needs. And I think that putting this together and what we're trying to look at is what are the needs of an individual who walks in our doors, and making sure that we are looking at making sure that there's things, for example, social determinants of health. I always believe people will not follow up with care because if they can't eat, they have no place to live, that's what needs to be dealt with first. So one of the things I want to do is to make sure that all providers are doing assessments of people when they enter the door for these needs. And also in terms of just equity, that people are receiving care that they need at the level that they come in the door with, and they're being addressed, and staff are aware of working with individuals who are different from themselves and making sure that they address their needs. So those are my two big pieces, which kind of cover prevention, social and emotional learning, and all of the listed below.
Yeah, absolutely. Thank you, Mimi. And yeah, HealthLink has been an absolute leader, thanks to in large part your leadership in this area. And so we look forward to your expertise and kind of drilling down on some of those specifics. I heard so many things in that little piece of things that we could, you know, dive into and jump into and make recommendations on and explore further. So I'm very interested. And just, you know, just for Alexis, I think Alexis is taking notes for us. And so, you know, the two distinct things there that came out, I think are so important. I think that are very appropriate for this group and probably will be covered by other groups and kind of merge our conversations. But the social determinants of health, you know, the kind of broadly speaking, the everything else that goes into how we live our lives, you know, as well as health equity. And I think those are two things we need to dive into. So thank you, Mimi. Ray, what do you think about this?
Well, thank you, Jay. And thank you, Mimi, and everybody. My name is Ray Lay, and I am a formerly homeless, honorably discharged United States Marine. I chose this group first and foremost because I live with a dual diagnosis, schizoaffective disorder and polysubstance abuse issues. By effort on my part and a lot of treatment, great treatment, I am just about 14 years clean and sober. About 16 years since I last was hospitalized for my mental health issues. And I am a proud community health worker, Indiana certified recovery specialist, and the longest serving veteran peer support specialist at Routerbush VA Medical Center here in Indianapolis. I have had the honor to work with DMHA on multiple occasions. I love it. I am a graduate of what's known as Whole Health Action Management. And when I first entered that program, one of the first things that Mr. Frick did, he wanted to talk about persons learning about their or knowing what was their current blood pressure. Well, I not only know my current blood pressure, I also know my A1C. I know all of my numbers. I'm gonna put it that way. And I'm well aware of that. Plus also, I have experienced homelessness for over 10 years, transitional housing, permanent supportive housing, and I'm coming to you live and in person from my home. So I believe that overall mental well-being is the epitome, the utmost of behavioral health. I've also spent time in both a state-run mental institution and a state-run prison. Tomorrow, the good Lord allow me to live, I will be back in a prison helping to train correctional officers, of which I've been doing for quite a few years, approximately 8 years. So I love doing it. It feels very good to walk into a prison and walk out an hour later. Excuse me. But as a 10-year Indiana certified recovery specialist, I feel very honored. I've had that opportunity to help train a lot, and I hope to be able to continue with that, and also to be a quote unquote example to others coming behind. Thank you.
Yeah, well, thank you, Ray. We really appreciate your perspective and attitude on these things, and you know, just the ways you contribute to our community are noticed and appreciated, I think, by everyone.
Thank you, Jay.
So, you know, I also should mention, both Ray and Mimi mentioned the notion of integrated care, so integrated behavioral and physical health care. And I know Barb and Aspire are leading the charge on that as well. So that's another thing I think that this group can kind of dive into. Barb, with that, you want to chime in here?
Yeah, sure. Thanks. I'm Barbara Scott. I'm the CEO of Aspire Indiana, and really honored to be part of this group. So I don't know how many more members there are, but I always think the fewer the better. So I'm glad it's kind of a small group. You can get more done. For me, I'm really interested in this concept of mental well-being. So I'm a licensed clinical social worker, and I've worked in the CMHC world. I'm on my 34th year. And so my very first job was the van driver, and had several positions in between, but the van driver still happens to be my most favorite one. I really, really enjoyed that activity. So here I've spent this lifetime, this career in specialty mental health, dealing with folks with complex issues. And I see our world continuing to change where there is, I'm okay with saying there's an increase in individuals who are experiencing serious mental illness. But I also see in our world that we are complicating, there still is stigma, and we're complicating issues because everyone uses terms interchangeably. So what I would really like to see Indiana do is get some mental health literacy programs going on. The Be Well site that was put in place for COVID, and Jay and Rachel, I don't know if that will continue. I hope it does. And we find a way to continue that. But in the youth section of the Be Well, if you go into that, there's a organization called Teen Mental Health, I think teenmentalhealth.org or something along those lines. Anyway, there's a mental health coalition, and there's this mental health literacy. And I would love that to come to Indiana, because I think it's going to do a couple things. It's going to decrease stigma, but it also is going to increase the time it takes for someone who does have a mental illness to get care, because it starts to clean up our language. The majority of people have really no mental illness or even a mental problem, but then there's mental distress. That's very, very natural, but we forget that in our society of no one wants to feel pain anymore. And so if they're that gets complicated. So you have many people saying, oh, I need access to care, where in reality, maybe what they're experiencing is very, very normal and will resolve itself with other things. And then there's mental health problems that actually are more difficult, like experiencing loss, death, grief, that kind of thing. And there's also multitudes of things that can help that, maybe counseling, maybe not. And then all the way up to mental illness. And so I would really like us to take a look at that information and see how we can affect Indiana's language so that we understand what we're talking about. I think that would help. And then, so literacy, as well as, I wrote some things down. Looking at all the elements of someone's health, what are really the health indicators for quality health, as well as life expectancy, and access to care, which is something that we all talk about, is only accounts for about 20% of someone's overall health and life expectancy. It's all these other things that Mimi has talked about and that Ray has talked about that really make up the bulk of someone's overall health, and mental health is part of that. So I would like us as a state to understand that as well.
Absolutely. Well, thank you. So, I'm just going to go over, I think, I believe we have a couple members that weren't able to make it today. We're scheduling 6 different subgroup meetings if anybody's watching. So it's been a logistical feat, which our team has handled, I think, very, very well. This is just the overall kind of charge. It's I think purposefully kind of vague. I think we already heard, there's already been a refinement in the 3 subgroup members that have spoken here of the things I think we're going to focus on. This is ultimately where we have these 6 subgroups, and we're going to all kind of come up with our own things, and we're going to filter it and talk about it and trade ideas and go back and forth. And ultimately our deliverable product comes in the form of reports or recommendations or suggestions directed to the legislature, but also directed, I think, to the executive branch. And I think we can also, and I'd like to encourage us to consider a broader audience. When you think of the private sector, or universities, or employers, or kind of civil society as a whole. But ultimately, we need to talk take all these things we're talking about and turn them into kind of concrete recommendations. And this is what the legislation sets out. And you know, as you can kind of see, it's again pretty broad. You know, there are certainly specific things in there that we have to talk about. And so, you know, I put this up there to say that the process of turning whatever we recommend into something that complies with the legislation is something that we are going to do later, right? We're going to figure out what works and what we want to talk about and what we want to do, and then we can format it or retrofit it into whatever the legislation says. And that's something I just wanted to make it clear that we're aware of it and we're aware of our obligations and fully plan on meeting them. But you know, I think that it's important for us to kind of take this conversation where we think it needs to go and not necessarily where you know, where the legislation started from. This is from the legislation of some of the other tasks that we that we were going to do. So we took that legislation and turned it into kind of some assessment areas for the different subgroups. And I think right here, right off the bat, just like I said, I'm not quite sure that all of these are applicable to this particular subgroup, right? They might be, I don't know. And so I think that we have flexibility to take a look at which one of these would apply and which one of these don't. I mean, you know, we already talked about kind of equity and social determinants. You know, system design, I don't really know if that is appropriate or applicable to this subgroup, but we can just say it's not really applicable. You know, funding is always applicable to everything, so I think we can certainly talk about that. Access to care, I think that we can kind of tweak that idea into something else and make it applicable. So all of this, I think, will guide our work, but we don't need to necessarily railroad it into, you know, what ultimately we come up with. And so I'm going to go ahead and stop sharing there. Because I just would like to leave some. I'm sitting in my bed, by the way. That's why if I have an unusual posture or you know, I'm trying to adjust myself. It's just I have a big purple cast on my leg, and so it's, you know, I'm doing what I can here. So more importantly than all of those things, I think for our subgroups, I think there are kind of two tracks that we need to operate on, and I'd like to get the subcommittee's feedback on these two tracks. I think track one, and this was mentioned in the agenda. Track one is, you know, discussing ideas that will ultimately form the basis of our like kind of ultimate big final product, you know, pretty bulky, you know, visuals, professionally developed report that we end up creating and submitting. So I think we need to start thinking about what are some of the sorts of things that will ultimately go into that report. Okay, so that's kind of track number one. And then track number two is what are the kind of lower hanging fruit or you know, obvious no-brainer things that we can talk about, that we don't necessarily have to wait until the whole commission, you know, comes together and approves a report and we develop the report, and you know, we're probably going to outsource the creation of it, you know, so it looks good and everything. And so in the light of those two tracks, like what do you all think about those as kind of like the governing principle of what we're doing?
Jake, could you explain the two tracks again? I'm so sorry.
Yeah, that's okay. I don't think it's so. Track one is the broad topics that we want to kind of examine and refine and explore that will ultimately go into the final product of this commission, whatever that is. And so, you know,
okay.
yeah. So you know, for example, integrated care, right? Like, I mean, I think we're probably going to make some specific recommendations on the notion of what you know, whole health and whole person care and all that. But that's probably not something that we could do without kind of convening or doing a lot more deep dives into different things, a lot more research. I'm working on getting us an army of graduate students to do some research for us. So hopefully that'll pan out. You know, that will go into this ultimate report, whatever those recommendations are, right? But I also want to not wait for that, right? And so I also want to think in terms of like, what are some kind of immediate easier or more consensus type things we can recommend and talk about and do in this. That makes sense. Oh, it's like Dr. Cohen is here.
Jay, that makes a lot of sense. And I would like to state that specifically is what you are asking is intertwined with everything which I believe everyone who is on this call has already stated. Specifically, Ms. Scott was talking about the language. That stigmatizing language, it can be totally defeating. Housing and behavioral health is totally intertwined there also. As a person can access more housing, hopefully, and more treatment, they can elevate themselves better. Okay, because when it's all over said and done, everything is on that person experiencing issues back. And that person hopefully needs to be supported to the point where they can realize, hey, I can do this, I can do more, so on and so forth, because that by itself can be totally liberating.
Yeah, absolutely. So we do have another subgroup member. I want to take a moment to allow Dr. Bowman to. So we asked everybody to do this already. So if you wouldn't mind introducing yourself and explaining what this subgroup, what it means to you and why you wanted to join, and also just some kind of preliminary thoughts about like what direction you'd like us to take in terms of the areas we explore.
Good morning, everyone. I apologize. My previous meeting ran over. My name is Sharon Bowman. I am a psychologist and professor at Ball State University. I'm also a psychologist in private practice and licensed as a mental health counselor. So I come at this from a variety of arenas. Mental well-being is part of everything I do, from the students that I train to the clients with whom I work to all the other aspects of my job. So that's my interest in this particular subgroup, both from a training standpoint and from a practice standpoint. I don't have a particular plan in mind for the group, so I'm interested in hearing where everybody else is going. And that's what I have. Thank you.
Absolutely. Well, thank you and welcome to the meeting. And no worries, we understand how these things work right now. Thank you, Ray, for your comments. As I'm listening and kind of trying to process in real time what we're talking about, I do think I see some broad categories emerging, and I think it'd be helpful. Because again, what we're trying to do is turn these amazing conversations into kind of discrete, reportable, and actionable items, right? And so, in order to do that, I think you have to constantly be kind of unpacking and categorizing, and it's a very iterative process. And so, I think this probably won't be the first time we do this. This will be, but as we start, the categories that I've heard emerge so far would be the social determinants of health. So that, broadly speaking, social determinants of health, I think that's a very appropriate, it's a very, very broad, I think, piece, obviously, but a very appropriate and broad piece of this puzzle. So SDOH, I've heard equity a couple times. I think that's, again, something that every group needs to talk about and we'll talk about. But I think equity from this standpoint is very important as well. And so I'd love to take a deeper dive into that. Integration of physical and mental health care, I think, is probably its own category. Again, these things are all related, but they're also separate, and just in terms of unpacking that. So that's number 3. And number 4 would be the whole kind of stigma awareness language, piece of it. So, those are the 4 that I've identified. What do you all think about those categories, and what, are there any others, or any other big category you think that we should take a look at?
I guess I was, and I'm not sure if the intent is for this to be covered in another subgroup, so let me know if I missed anything, but the idea of prevention or early intervention Is that, do you think that would be appropriate for here?
I mean, there is another subgroup, but I think that again, we're inventing this whole cloth as we go. So I don't know that there's necessarily like a right way to do this, but I think if we want to talk about it, we should talk about it. And then I'd rather be redundant than miss something. So
I think with that in mind, as we're talking about social determinants of health, I mean, we will never get to a point that everyone's social determinants of health are perfect and setting everyone up for total success. And so in those instances, that's where prevention and early intervention are really, really important. And I mean, I think we've seen with every substance abuse epidemic that we have had hit us as a nation and as a state, that if we had been more proactive about prevention, early intervention, the amount of cases that we had would be dramatically different. And I think, we due to payment structures and all of the things that we can talk about later, our ability to focus on prevention and early intervention is pretty stymied at this point. And I think it is an incredible need.
I think jumping on that, I'm looking at with integrated care, the expert assessments. So when someone's coming in, assess their depression, assess their anxiety, assess their substance use, assess their alcohol use. And that, in hospitals and emergency rooms, everywhere, because I think that is
would you mind unpacking what SBIRT stands for?
Oh gosh, screening, brief intervention, referral to treatment. So those are screening tools that are used when somebody's coming in the door, that's when we use them, and to assess these mental health issues of what that person may need, where they might have come in for a broken ankle. And this is a good place that you can ask these questions. Are you drinking? How much are you drinking? Which triggers more treatment to address the behavioral health needs. And I think the big push was to have these screenings done in the emergency rooms. We do them when someone is new to our clinic. So I think as we talk about prevention, that's a big piece that we need to roll into this, because it is, when it's used and these assessments are paid attention to, is a good way to identify what are issues that are going on and what we can do for early intervention. So
I'm going to ask a couple I'm a lawyer, so I'm going to ask a couple follow-up questions there, if that's okay. I think I'm really trying to get us to like a very specific place. So with SBIRT, I completely agree that it's something that I think we could use and build. What would some general specific recommendations look like ultimately for that? Like what how would you phrase that or frame it in terms of what else?
First of all, that staff are trained, different types of organizations are trained on the existence of these tools, number one, and then look to how these can help you prevent, address early on any issues. I'm not saying it in a policy because I got to think through that. There's a little more time thinking about it.
We'll have plenty of time. This is, I get
it. But I just think that it's something that's, a lot of work has gone into that. Different places, different states have it at different points in process of how it's being utilized. And I think that making that more of this should be in every setting that is addressing behavioral health.
This is the evidence-based, right? This is the evidence-based model. And
oh yeah.
Yes.
Yeah.
And so I guess I would also say I would love to see this be expanded, whether through partnership with the CMHCs or the how, I guess I'm not quite there yet, but I think about how we could mobilize teachers and educators for our young people.
DCS.
About the incredible stress, DCS, and I'm thinking even before DCS, but definitely DCS, is how can we educate and support whomever is naturally children's lives as a support person to be able to quickly identify issues and then streamline connection to the resources they need. Because I mean, we know with trauma and with social determinants of health and things like that, that one positive intervention can really make or break the trajectory of a person's life. And, you know, there are so many, I used to work primarily with the criminal justice population. And as I would learn about people's life stories, I mean, I would just see countless numbers of opportunities for intervention that had been missed. And, you know, and I think that is a sign of how we fail as a system and where we have a lot of opportunity for doing things better.
Rachel,
I see your hand up.
Yeah, I just really agree with that. I think if we had, so SBIRT is something in the FQ world and primary care world, brief screening for intervention and referral. I think the CMHCs could do that and actually could do that on many situations instead of those bigger comprehensive assessments that we do. And I agree with Rachel. I think it does fit in the schools. I would love to see the schools, every child be screened annually for the social determinants of health. So it's, you know, you're gonna identify families at the start of every school year because it changes obviously year for some. So you're going to know what children are going to need interventions. And so, and beyond just interventions, the act of screening questions is an awareness for the individual who might not realize that what they're experiencing is something that needs to be looked at. And it may take multiple times of screening just to begin that concept of prevention and intervention. So one of the things we're quick to want to do is intervene, but sometimes the people aren't ready for that and they just need to hear it. So just imagine a family who hears it in their primary care office and hears it at school and hears it at DCS, and they begin to just hear it over and over. That I think is wonderful. And then I cannot agree with Ray more about sometimes that intervention is not a physician or a psychologist or a social worker. It's housing or it's employment or it's connections to benefits or whatever it is. That really is what the person is ready to engage in.
Something I'm working on with DOH is just the whole, and Ray, you're at the conference today, the whole piece of community health workers and their role and their connecting to people and how right now FQHCs cannot bill for those services, but what they are able to do and the connections that they make is a role that I think that we found, we now have 9, but it is an integral part of really, you know, like the hub and the wheel bottle of really getting this to work. And so I think looking into that position and the role it plays in mental health, because sometimes they get that information before anyone else does. If somebody's feeling suicidal, if somebody's not feeling good about themselves, and they can intervene because they're getting that information that somebody is not, someone else is not. And I know it's, you know, through healthcare, but it really can be used in mental health and especially in integration. So that's a role that I think does need to be kind of explored and looking to see if we could get funding in this state for, because the work that they do, a lot of us, you know, I'm a trained LCSW. I can't get some of that information that they can get. And they get it just like that. And I might take 2 sessions to get that information, but very similar to the peers. And how do we look at the benefit of this position in helping with somebody's overall mental health or well-being?
What
Right
I would
along
like
with
to
what
do,
you just stated there, Ms. Gardner and Dr. Scott or Ms. Scott, I
Yeah.
have both of you ladies are licensed clinical social workers, and I have had the honor to work with an abundant amount of licensed clinical social workers in my role as a recovery specialist / veteran peer support specialist, specifically with our intensive case management team, specifically for veterans with schizophrenia, schizoaffective disorder, bipolar disorder, post-traumatic stress disorder. And I utilize mainly that expert, but I did it with a motivational interviewing aspect or focus. And it was so great that they kept asking me to take a job, but I do have quite a few different modalities. And my first job is for me to live with my schizophrenia to the best of my ability. That is my first and foremost job. And so instead, help create a job for someone else. Did a webinar with the United States Department of Justice and the United States Department of Veteran Affairs. And as soon as probably within the next month, we'll be doing the same thing to help create another job for veterans involved with the criminal justice system. Another aspect of that I would state is that the expert should be working or at least somewhere along in that language for the criminal justice system, Indiana Department of Corrections, and also any trainings specifically around the state. So hopefully that same system can be utilized to help, as you just stated, that constant axing, because it can turn on a light. My psychiatrist used to always ask me, you ready to stop smoking? You ready to stop smoking? You ready to stop smoking? I have not had a cigarette now in over 12 years. And it feels good. It works. It works.
Right.
Okay?
Yeah, I mean, I think you're demonstrating, Ray, that the science, the research says that just merely asking you over and over and over is what eventually helps. What I would ask Jay, is that on the bucket of prevention and early intervention that you acknowledged with Rachel, is I would put the word engagement before that. Engagement, prevention, and early intervention, because I think Mimi and Ray are really speaking truth. And it's so cool, right, Rachel and Jay, because we know these LCSWs, one, Mimi is right. We are not the people that get that time sensitive information. And two, there's a shortage of us. So how beautiful it is that we can create a workforce that actually is better at engaging people through community health workers and peer specialists, because those LCSWs aren't going to be around. I mean, we're not, and psychiatrists, oh my gosh, they don't even exist. So yeah, I would use that
I
word.
really like the engagement addition to that, because I think that we're demonstrating, I think, you know, the conversation itself as the intervention, right? To a certain extent. And
Yes, yes.
Yep.
and yeah, no, I think that I think this is something we can definitely turn into kind of an actionable recommendation type item. So I'm very excited about that. Sharon, were you wanting to add something?
No, I was just nodding my head in agreement. I love the engagement idea.
Well, cool. That's really helpful. So yeah, I think we have a nice framework then, and we've spent a lot of time talking about the early engagement, intervention, prevention, and I think engagement might be what differentiates this particular subgroup from the other subgroup. That's probably gonna do a little more of a deep dive into some of the gaps in treatment and those sorts of barriers. So that's a good one. What about some of the other subcategories? Does anybody have any thoughts on any specifics we should talk about there? We've talked a little bit about housing. You know, housing is I think probably the most prominent of the social determinants issues. And I know from my previous experience, you know, one of the most important ones. It's also a multifaceted, multi-system you have zoning issues, you have affordable stock, that affordable housing problem itself is probably one of the most pressing issues. Disregard mental behavioral health across the board, right? I mean, access to affordable housing is a huge issue. And I mean, I don't want our recommendations to be so broad that they're meaningless. Like, Indiana should do more to invest in affordable housing. Well, yes, Indiana should, but what does that actually mean? But is there any way to turn a discussion about housing into sort of a specific actionable recommendation?
Well, I have a couple thoughts on that, Jay. One, at Aspire, we say housing, affordable housing and supported housing, while we need more of it, is still on somebody else's dime. And that unless you help individuals earn a livable wage, we'll never have enough housing stock. So we have to be able to move people to where they can afford their own. So, and I know funding for employment has gone down in this state. So I think those go hand in hand. So that's the first thing I would say about that. I would include employment in that. And then there's something else I was going to say, but now I can't remember. So I'll shut up and let
Well,
someone else talk.
your comment actually, Dr. Bowman, one of your colleagues, Michael Hicks, writes a lot about, the kind of somewhat mirage of Indiana's economic boom, in the sense that it's come, I think, disproportionately in the form of, very low level, low paying, low wage, I don't like to use this term, but low skilled jobs. And I'm wondering if we shouldn't engage with him or some of those folks in that world to talk about the connections between these two things, because ultimately, I mean, I think you're right, Barb, like the overall mental health and well-being, I think that that access to employment and not only employment, but employment that allows you to provide for your family is a driver of that. I don't think we should ignore it. I mean, I don't think we should spend all our time on it, because it's not necessarily our lane, but I think it's relevant enough that it's probably worth some exploration.
Mm-hmm.
I would throw in not just employment, but also disability. Because if you are on disability and you don't have the money to pay for your housing, frankly, it's the same issue.
Absolutely.
And me, Jay, I don't know if you knew this or not, but I just recently rolled off the Indiana Balance of State. I was on the Indiana Balance of State Continuum Care board for approximately 7 years. And I constantly used to emphasize that when we come up for funding at funding issues and going after HUD funding for the 91 counties that the Balance of State is responsible for, under the leadership of the Lieutenant Governor. But now, today, I'm still a member of the board of directors with CHIP, the Coalition for Homelessness Intervention and Prevention. And we actually were just talking about that yesterday, okay? Harm reduction is real, okay? But also we still have to, as Dr. Bowman just stated in so many words, that inclusiveness, lower all barriers. There should not be no barrier to either housing or health care.
Yeah, so I mean, an example I think is, I don't know the ins and outs of this program, but it's something that I think we should probably explore and learn more about. Is there's a few different states, and this is where being an FSSA employee clashes with being the chair of this commission. But I'm gonna go ahead and say it anyway. There are a few states that do actually include some housing support in their Medicaid program, for example, because of the idea of housing and healthcare.
I was just going to say that. It'd be
Yeah,
cheaper.
and frankly, I mean, that's something I think that we should probably learn more about. Alexis, if you want to put a kind of flag there in terms of like, let's learn more about that. and talk about it. Is that something that we want to recommend that FSSA consider, is applying for a waiver or whatever the mechanism is? I think that we'd probably find a bit more friendly federal administration during the next 4 years for that sort of thing. So.
And Jay, I don't want to miss your earlier comment about Michael Hicks or some economist who might speak to that piece of the puzzle. I think that's a nice side point to where we're going. We do need to understand, we can all talk about it from a mental health and well-being and here's what happens in our world side. But to have an economist also talking about it would be a really good idea.
Yeah, absolutely. And I am a undergrad Cardinal, so I think maybe that might be a little bit of a connection there. But probably you have a much better one. So that's something I think Alexis may make a note. Maybe Dr. Bowman and I can reach out and engage with Professor Hicks or somebody like that to kind of chat about because again, I think that our challenge here, and I'm always talking about our challenge, but I think it's important to note kind of like what a monumental task we're undertaking here is we have to cast a very wide net.
Right.
Like we have to, let's think about all the different factors that could influence the mental health and well-being. But I think we have to be very, very discerning about which one of those factors are appropriate for inclusion in our report and which ones aren't. And so I think that that's and to me, I think that's certainly at least worth the conversation. Like, is the overall economic climate of the state and its impact on mental health and well-being appropriate for the Behavioral Health Commission ultimately to opine on? And I think that you'll probably have some strong opinions both ways if and when we take this to the commission as a whole. But I mean, I don't think we can shy away from differences of opinion. I think that's something we need to embrace and work on hammering out.
And Jay, just to kind of circle back around to your statements at the beginning of this meeting, correct me if I'm wrong in my conceptualization, but it sounded like recommendations to the commission would be for strategies or issues that we need kind of larger buy-in, larger partnership to make move. And then at the same time, we have, when you mentioned low-hanging fruit, there are things that we could, rather than waiting for the commission report to be finalized and all of those sorts of things, these are things that we could say, oh gosh, this is something that would be a relatively quick fix. Maybe, Rachel, you could work on that with a few of the CMHCs to get this moving now, rather than it having a big heavy lift. Does that sound like a correct conceptualization?
Yeah, exactly. And if it does involve, for example, so I guess there probably is a subcategory to category number 2, not to use the hell out of everybody else. But the low-hanging fruit, like there may be lower hanging or obvious things that might require, for example, legislative intervention that could be recommended before the 22 session. Mm-hmm. The legislature. Maybe not in this area in particular. This might be, these are, I think, more either the things like you mentioned, Rachel, that we could work on in a small group, or kind of bigger things that we need to maybe have vetted by the whole commission. But if there is anything that require, I don't think we should wait for the 23 session is what I'm saying. I think for recommendations, if in fact we can think of some things that we can prepare an interim report to the legislature, for consideration during the 22 session or something. So this is all very confusing and big, and so I think that we're just trying to break it down and make it manageable. Barb?
I have a question for consideration. So one of the things I learned from our vice president of primary care is she's a nurse practitioner, and she talks in terms of prevention. When I hear prevention, I always think an intervention of some kind, whether it's professional or informal, that prevents an illness. And she said, actually, I was thinking of it wrong, that there's prevention even within the concept of illness. And so she gave an example. If she's working with someone who's diabetic, she still has prevention activity to keep them from getting worse. And so I'm wondering, and I don't have a suggestion here, it's just a question, so far the things we've talked about are pretty broad, but are there specific things we need to call out for people who already they're already in that, remember I talked kind of that pyramid earlier about where you're at, and let's say they do have mental illness. Are there prevention things that we should be doing? Like example, if someone's been in DOC and they're now not using, but now they're coming to the close of their sentence and they're being re-entrified. It's not a word. Housing then for them, or access to higher level of, they go right up to the queue of specialty services. In that regard, we haven't talked in that regard when we're talking about mental well-being for people who already are in our systems with mental illness.
Yeah. I mean, yeah, absolutely. I think that what you're alluding to, Barb, I think is as much a matter of practicality, right? Because they're already there, right? So we might as well reach them while they're there, right? They're already in the system. And I certainly think I think that this kind of brings us full circle to kind of Mimi's opening point about SBIRT, is that the proliferation of these things needs to be so much broader. It needs to be every single DOC inmate. It needs to be, every DCS family. It needs to be not only every DOC inmate, but probably the families of the DOC inmates, if we could reach them. I mean, that's in the least intrusive, most culturally sensitive and competent way possible. I mean, that's the caveat that underpins this whole thing, is that we don't want to become the state that's going to ask you about your business all the time if you don't want us to, right? But there's probably a fine line to balance there. So yeah, absolutely. I think we do need to do more. I mean, because ultimately, I've always thought about this whole world, like, broadly speaking, social health and human services, this world, as having kind of a vertical and horizontal axis, right? The vertical axes, or the vertical things, are the different services, right? The mental health, the behavioral health, the substance use, the whatever you want to call it. But this world has a horizontal impact too, right? And this group to me is much more about the horizontal kind of cross-industry impact across all the different verticalities. So, both public and private. You're talking about employer groups. The Indiana Chamber has been a great partner over the last couple of years on this. And I think it's our job to figure out what we can take to all those groups in terms of this, and give them tools and resources to get the necessary buy-in to get to the world that we want to get to, right?
Yeah.
Go ahead, Brian.
Excuse me, Mimi and everybody. One aspect of what Barbara just stated is concerning with that criminal justice aspect. Just tomorrow, God willing, I will be back again at Plainfield Correctional Facility, helping to train newly hired correctional officers on mental health issues. For approximately 7 or 8 years, I've been doing that. But yet I don't have that opportunity, or I have not been given that opportunity to work with persons experiencing mental health issues while they are incarcerated, prior to them being released. So, which, although I have had the honor to work with quite a few in the parole system, in a couple of parole districts, until I was actually literally told, we're not sending enough people back to prison. we're gonna have to let you go.
Mm.
I've actually been told that. Okay, so I wholeheartedly agree with what she is saying. I've been saying it for the longest that we need to work with those persons. The prior commissioner of the Indiana Department of Corrections, to quote him, 95 out of every 100 that enters Indiana Department of Correction will leave the Indiana Department of Correction and return to the community. Do you want them with treatment or without treatment?
Yeah, absolutely. And I think that's that's something we should tackle in this group. And we do have I should point out for the people watching, we do have a criminal justice interface task force specifically, but I think that all of these principles, need to be understood. Again, I'd rather be redundant than miss something. So
I think
Well,
it makes
Jay, I
sense
also-
that, oh, sorry. I was just going to add, as I'm taking notes, Alexis and I are taking notes, and that we've brought up a number of things that potentially overlap with other subgroups, but I think that makes absolute sense, being that this is the overall mental well-being group. And so I think it'll be important for us when we take these things back and kind of confer with the rest of our internal work group, that it will work. I think it's great that these potentially can have overlap and really make connections between the different, overarching subgroups that we've identified. So I'm keeping note of those things, and I think it's really great that these are coming up, and I'm noting where the overlap is, and we can kind of review that in our coming meetings.
yeah, thank you, Bethany. I really appreciate that. And I think that it's important to note that there probably won't be any recommendations of the subgroup. These are all going to be recommendations of the Behavioral Health Commission as a whole, right? And so this is just kind of how the sausage is made, and because of public access laws, we have to broadcast that to everybody. So, and I also want to point out that Bethany and Alexis and really our whole Behavioral Health Commission team are absolutely fantastic note takers. I did not know that until I saw the minutes they had put together for some of our meetings. I was just like, holy crap, this is way better than I could do. So I'm very grateful, and I think we're very lucky to have them helping us with our work, kind of keeping us on track, so we can just kind of brainstorm and pontificate, knowing that our thoughts will be not only recorded and organized in a way that makes sense.
I have a new topic. I don't know the relevance here, but yeah, thinking about correlation between physical disease and a mental health diagnosis. So looking at diabetes and say, I don't know, anxiety, or I'll say depression, hypertension and anxiety, and just looking to how can we, because there's a lot of research out there on the combined disorders and how they feed on each other, some pre-causal to that disorder. I don't know where this would fit, but having some discussion about it, having where, this is on the hospital side, this is a lot of their HEDIS scores and all that kind of stuff, a lot with the MCOs, this is, requirements that they have to, but somehow if that could be, I don't know, but it hits me because it's something I see every day. And I just want to speak to it. And like I said, I don't know if it fits here, but just looking at what we can do in terms of, there's research, evaluation behind it, looking at the cross training of providers to understand that these things are related. Any thoughts?
Yeah, no, I mean, I think that's really relevant, because I was reading an article about COVID, for example, and how something like a third of people with COVID are now being diagnosed with mental or neurological, or whether or not they're actually organic neurological, but mental health conditions, right? And so certainly worth, I think, putting a placeholder in to see about talking about or examining the interplay between, or using whatever, now that we have an all-payer claims database, for example, there could just be some number crunching or data crunching about
Not a
the-
student. Yeah, like I said, I don't know what to do with it, but it's so relevant and we see it every day. And now it's, you know what I mean? I don't know what to do with it, but, and this might not be the forum, but it's an issue. And what do we need to do with it? So.
I will say that there tends to be kind of a dichotomous approach to how clinicians tend to do their work in terms of, okay, so just as an example, one time I was leading an outpatient team and I, was telling them, hey, part of your clinical assessment needs to be including whether or not they have any physical health diagnoses that are self-reported by the client, right? Because then if they have diabetes and we say, okay, what medications are you taking? And they're like, oh, I don't take that stuff. And they're depressed all the time, probably connected. And within that team, there was like kind of a low-level revolt that we're not medical doctors and we're not going to put diagnoses down that that are medical in nature because, and trying to say, okay, first of all, you can just say per client self-report. And then this is about like care of the whole person. And so I guess what I'm saying is, while I do absolutely want to be cognizant of administrative burden, I think there is still a perception that mental health and substance use disorder providers only speak to that small segment of the person. And I think I think a gap in overall well-being is helping clinicians understand how do I screen for these other issues and then make associated referrals? And how can we do that with, there's a way to construct your team that you have people with associate's degrees, as an example, helping be healthcare or something like that to help follow up on the care of the client. This, I think, also speaks to, the movement toward integrated care. I'm rambling a little bit, but what you're speaking to, I definitely have witnessed. And I think there are so many opportunities that we as providers miss because we are having so much tunnel vision in our own scope of practice.
Mm-hmm.
Rachel, if I piggyback off that, I spend a lot of time talking to my students about asking medical questions. Ask about their doctors, ask what they're telling their doctors or what their doctors have said to them. We see our clients, patients, whatever you call your people, we see them way more than any of their medical providers do.
Mm-hmm. Mm-hmm.
I have clients who have 15 doctors, and I wish that was an exaggeration, but it's not.
Mm-hmm.
15 physicians, but they see me weekly.
Mm-hmm.
So the one person who can say, you need to go have a conversation with your provider, and here's what you might want to ask. I'm the person who can do that because I'm the person who sees them. And I agree with you, getting more people to use integrated healthcare in that way. I'm not a physician and I'm not an attorney, Jay, and I tell them both of those things all the time. But I need you to go talk to somebody who is a physician or who is an attorney and have this conversation.
Or even having, like with DCS, you have the child and family team meeting members where you get everybody to sit down together, having that in behavioral health and the PCPs. Or having that, I know it's a checklist, like, on a lot of the different assessments, but what's the next step? What's happening? And then the other piece that comes into mind is that, as you said, they might have 20 doctors and then they have the medication from the psychiatrist, and these medications sometimes don't work together and they conflict. And so who is going to, unless you have a very smart pharmacist who's actually very involved, that's where this stuff gets caught. Mm-hmm. So making sure that providers understand medicine that is for diabetes, whatever, so that they're aware when they're working with the client that it is their responsibility to look at all these meds and catch any, conflicts that will cause damage. So.
And I think so much of that is connected to our responsibility to reduce administrative burden, because I do, just in my own experience as a clinician and leading clinical teams, I think the negligence around asking medical questions, ensuring that those referrals are in place, making sure that I'm collaborating with physicians and things like that. I often truly, I think it starts with lack of education and understanding, and I think it is exacerbated by lack of capacity and time to actually do that legwork. It is very hard, and it's time consuming, and trying to get a hold of your own doctor is hard a lot of the time.
Yes.
So then, and a lot of times the clients will say, like, I don't know, I think it's like Dr. Jones or something, and she does something for my neck, and you're like, okay, what the hell does that mean? And so, and so trying to figure out, okay, how do we, and how do we stop seeing mental health and substance use diagnoses in isolation, I think is also really important. So I'll step off my soapbox now, but that was something when you brought that up, it just really kind of sparked that experience in me, and it has been, I think you hit the nail on the head.
So yeah, I mean, I think that's a great conversation, and bringing that back to how we can, ultimately, I'm thinking like 10 steps down the road, but ultimately how that would play out in some sort of recommendation or report. I mean, is that kind of like a clarity around scope of practice issue or like education? Like, I mean, what are the levers that we have accessible to us to recommend pulling or pushing to influence that?
I think that education, also cross training in different systems. I know from history, I know a lot of like psychotropic medications. I'm not a prescriber, but I at least understand them. Now I understand a lot of, on the other side, medicines that are used for diabetes. And I understand and it helps that I have pharmacies, pharmacists that I have access to. I can just I can text actually and get the answers. But training people, maybe in school, I look to Dr. Bowman, that these are things they're aware as they're getting out of school, that this needs to be part of their practice. That's like a very simple one, but being able to address those issues. And then how do we, because for example, I'm going to think of in your addiction policies where you have somebody who's pregnant, and how you require that the physician who's prescribing methadone or whatever talks to their OB doctor. And that doesn't happen, but it's supposed to happen. So how can we beef up regulation that even that's put into something that conversation is it's noted that connection needs to occur, because you do have that in regulations for the pregnancies.
Mm-hmm. Along those lines, me myself, I have done a lot of self-psycho education. And I also come to find out that, I don't know if I know there's no psychiatrist on this call, but we do have a Dr. Bowman, a clinical psychologist.
Yes.
Am I right?
Yes.
But what's known as the CATIE study, Clinical Antipsychotic Treatment Intervention Efficiency Study, a research study concerning the old antipsychotic medication and the new atypicals. I am a walking CATIE study because I was on the old antipsychotics, and today I'm on the atypicals. And one thing that I have come to find out, that the very hardest part concerning mental health issues and all the co-occurrings is to accept your condition. It's a very, very hard thing to do. But once a person does do it, I believe that what helped me tremendously was the fact that I decided to want to learn more and be honest with myself and accept what's happening with me, and also learn other ways how to live with them and live with them better. And this is what has helped me. And I believe that, and I do know for a fact that we can help teach this, train this into specifically my colleagues who are also recovery specialists. And I've also been able to work with it working with my licensed clinical social workers, my nurse practitioners, and some of my clinical psychologists. I have had the honor to work with quite a few clinical psychologists. Work with one now constantly. I'm at the VA hospital at Rowderbush VA Medical Center. Prior to the pandemic. But I just received word last week that we're getting ready to open back up. All right, so I most definitely am anxious about that for the simple reason I am also anxious about the fact that I might have an opportunity to work with some more people again. All right, and I mean, man, that's something that makes me want to get up in the morning and stay up late at night, although I'm gonna be in bed by 8 o'clock because I learned to take care of myself. Okay, please forgive me.
I love that. You know, when I'm listening to all of you speak, the thing that we fall into is mental health well-being. Well, what is it? And it is not the absence of mental illness. So Ray is a really good example of someone who has a mental illness, but probably has better mental health than someone who doesn't have an illness at all, because he's actively taking his medications and in care. He's engaged in purposeful behavior, some other things. You know, I have a home. He said, I have a home to live in. I'm employed. I have purpose. I'm socially connected. I don't know if you're sleeping well and eating well. So, you know, I have maybe I have diabetes, but I have that under control. Those are all mental well-being. Those are elements of mental well-being. It's not this, oh, we got to get people with mental illness into care. That's what that mental health literacy does. It helps clarify what we're talking about. And Jay, I saw you had a question about mental health literacy.
Yeah, I can just, my question was, you know, I was talking more about like, you know, like, I don't even know if they do this. I mean, you know, that's how disconnected I am from the education world, but like, you know, if they still do health education in high schools, for example, you know, is there like a mental health portion of that curriculum, or I don't even know if they still do that. I know it's a controversial topic on many counts, you know, so I just was wondering if anybody knew, or if that's something we should explore or look into.
I don't know what the
Yeah.
school system, because I don't have children and I'm less connected to the school training than I used to be. So my response to your question had to do with how we are cross-training professionals. Your question's a good one. I simply don't know what's happening with healthcare. I can ask around about that.
Bethany, do you know?
Yeah.
Bethany is our school-based coordinator, so I don't, or no, director. Not sorry.
I do wish that Brooke Lawson was here. I think she would have a really great, insightful answer for us. But I think in general, I would say that it varies widely across the state. You know, and that just comes down to all the things that we've talked about, including stigma and understanding and education about mental health. And you know, we've got a lot of schools that are building capacity and competency within their school staff, from teachers to administrative staff, around mental health and just that general language and what does it mean, and you know, who are your providers, and building that understanding of mental health. But I think, you know, we've come far, but we've got a long way to go. There's plenty of schools who are not, I would say, including mental health and health education in a meaningful way, maybe, you know. So certainly we're working with a lot of schools to try to do that. But I think Brooke would be able to speak to that, because I know HSE, where she is from, Hamilton Southeastern, they're doing a lot around mental health. And so she could kind of speak to maybe what their schools are doing, which would probably be more than many other schools across the state.
Yeah.
So we can maybe kind of put that question to her after today's call.
Absolutely, that's great. I think we should also point out that I think with that, I think cultural competency is such a huge piece of that particular element. I think that So I think exploring and making recommendations about, mental health literacy and that being delivered in a culturally competent manner are things that we should explore too. We've got about 11 minutes left. So
yeah, I have a couple websites I can
course.
send on mental health literacy that I'd been looking at and sharing.
Great, thank you. Go ahead and send this to it. We'll include those in the minutes.
Okay.
I just would like to add and clarify one little aspect. Ms. Scott, you stated about me having diabetes, or maybe that's what I heard, but no, ma'am. I at one time was pre-diabetic, and a dietitian talked with me and explained to me about counting my carbs and also increasing my exercise. I make it my business to try each and every day, at least 5 days a week, to walk at least 5 miles a day, constantly at one time. And also, I make it my business to only have 45 carbs per meal.
Yeah.
Okay.
No, I'm
And-
sorry. I was indicating you had diabetes. I went from your story to a broader general concept. So
Yes, ma'am.
it does not surprise me that you were educated and you're following it. You're an amazing. You are a unicorn. Nobody follows the advice like you do.
Wow. Well, thank you for that. But better than me, it being about me, I feel like giving back as much as I possibly can. That intangible, which I believe is one of the greatest, and that's hope.
Okay, so we got about 9 minutes left. I think it's been a pretty productive meeting so far. Actually, I'm very happy with how it's gone. I was unsure about how this subgroup format would flow, but I think so far one meeting in, I think I'm pleased with that direction that we've taken. Does anybody have any kind of concluding or other remarks about what we've talked about or something new?
I just would like to ask concerning. I also signed up for the criminal justice interface, and so I do believe that they kind of like are all intertwined. So I will be most definitely sitting in on that subgroup also.
Yeah, absolutely. And the nice thing about having, either one of Rachel or I or both will be at every subgroup meeting. And then we're going to have 2 DMHA staffers at each subgroup meeting as well. So hopefully we'll be able to make those connections that we on the same page. One piece of housekeeping, I guess, that Bethany reminded me about, and I don't have an opinion on this. I could sort of go either way, but I will throw it out to you guys. Does it make sense to go down that kind of formal Robert's rules, selecting a chair for this group, or what do you all think about that?
Maybe when it come time for us to help write the report or make contribute to the writing of the report.
Yeah, so my thought is this group is so small that I'm thinking like for right now maybe a chair is not, selecting a chair might not be necessary. I think that
I would agree with you, Jay.
For some other groups that are in some cases maybe even twice as big, it might make more sense.
This is small.
Yeah.
You might
Main thing. Oh, sorry, Barb, go ahead.
You might want to, in looking at the duties of the chair, reporting out to the larger Behavioral Health Commission meetings. I don't know what that's going to look like, but I know, Jay, you might not want to have that dual role, and you might want to assign it to somebody just so you don't have to be so active in that meeting that you facilitate.
Yeah, and that's probably a good segue to our next conversation, is like in terms of like how many more meetings do we think we need to have before we're ready to go to, because we're thinking about convening the larger commission again in kind of August or September, around that time. So I think, we probably should have, I think here's what I propose for next steps. Let me know what you all think. And again, the shifting around I'm doing is because I'm just trying to put my leg in a position where it's not killing me. So, I think we should let Bethany and Alexis put these minutes together, kind of see how they look. And I think we should probably schedule at least one more meeting of this subgroup. But I think between now and then, every subgroup member should be tasked with turning whatever portion of the minutes or notes that they think are appropriate or of interest or relevant to them into something somewhat actionable under the kind of tracks I laid out. So when we can send this all out, so that the tracks being, this will ultimately inform this should be put on the table and explored further for consideration for the broader commission report. This is something that might be lower hanging, easier to accomplish. That should be explored differently, that in some form or fashion like that. So and then reconvene and kind of have a more targeted meeting where we kind of knock out all of those discussions in one meeting. Does that make sense?
Mhm.
Okay.
Yes, sounds like a good plan.
Mhm.
Okay. I'm trying to avoid the meetings to plan the meetings to plan the meeting type of thing. So I think that let's turn this from this is a great kind of broad discussion. I think we appropriately funneled things in the manner that I wanted to, and I think at that next meeting we can decide the mechanics of who kind of does that report out to the next commission, to the commission as a whole. Alexis, I saw you raise your hand.
You answered my question just as I was about to ask it.
Okay. All right. Okay, anything else before we adjourn the first official Behavioral Health Committee Commission subgroup meeting?
I would
Well,
ask,
first,
do we want to select a,
What was that,
sorry,
Beth?
Barb.
I
I
said
was
first will always be your favorite.
Yeah, no, I think that might be true here.
I was just going to ask, do we want to find a date while we're all together instead of doing another doodle poll situation?
Okay.
How long do you think we should go before we come back together?
I was thinking early June, probably the first half of June. Would be, does that what do you all think about that? Like the first 2 weeks of June, they'll give us a month to get together, and we can continue the email conversation about if there's additional research or folks we need to talk to, we can maybe do those on a one-off. I think as long as it's only a couple of us, we don't have to worry about public access when we're talking to if Dr. Bowman and I want to talk to Michael Hicks or whoever, we can do that. Okay, so maybe first 2 weeks of June, and I don't know, Bethany, do you want to throw out dates, or do you want to do that by email, or how do you want to?
If everybody's cool with like a Tuesday at 11, like today, we could do Tuesday the 8th at 11 to 12:30 again.
Send
I
it
can do
now.
that. Yeah, schedule it now.
I know.
Works for
That's what I'm
me.
trying to do.
Yeah.
Is everybody on board with that?
Yeah, this is Ray Lay. I'm good with that one.
Okay.
I am teaching this. I'm teaching this summer, and I don't know when my Tuesday class is, but go ahead and schedule it, and I'll figure it out.
Okay, and we can always, we can be flexible if we need to be, but just to get something on our calendars, I think would be good.
Yeah, I agree. Thanks, Bethany. Okay. Well, thank you all for your time and your insights, and let's not hesitate to keep this kind of conversation going, via email or whatever. And if you have any other thoughts or ideas, I think that your invitation is always open. We can always insert things into minutes or whatever later if you think of something you didn't come up with. So,
Thank you.
Thank you. We have a great day.
Thanks.